At Dana-Farber Brigham Women's Cancer Center. She's an assistant professor of surgery at Harvard Medical School. She's going to talk about local therapy and quality of life outcomes in young women with breast cancer.
So thank you, Dr. Osborne, the committee, and thank you all for allowing me to present our work today. Have no disclosures. So more than 13,000 women who are 40 and under are diagnosed with breast cancer each year, and they make up about 7% of all women diagnosed in the U.S. with breast cancer annually. Despite the fact that there's equivalent local regional control and survival with breast conservation and mastectomy, the rates of mastectomy, and particularly bilateral mastectomy, are increasing in young women, with a 10-fold increase seen from 1998 to 2011. Young women are at particular increased risk for poor psychosocial outcomes following a breast cancer diagnosis and in survivorship. However, little is known about the impact of surgery, particularly in the era of increasing bilateral mastectomy, on the quality of life of young survivors. So we sought to use a multi-center prospective cohort of young women with breast cancer to evaluate differences in quality of life among women who had breast-conserving surgery, unilateral mastectomy, and bilateral mastectomy, and to identify the demographic and treatment-related factors that impact quality of life. We used a cross-sectional study design, and we used the BreastQ, which is a validated quality of life instrument used internationally that focuses on health-related quality of life after breast surgery. We administered it to all eligible participants within a defined young women's study cohort who were in active follow-up from 2016 to 2017, either as a standalone survey or as part of their 10-year follow-up survey questionnaires. The median time from diagnosis to the BreastQ completion was 5.8 years, with a range from 1.9 to 10.4 years. And demographic and treatment information were obtained from serial surveys and from chart review. This is our consort diagram, where there were 1,302 women who had enrolled on this prospective cohort study. We excluded those women who were found to be ineligible after enrollment, those who only filled out short-form surveys, who were deceased or lost to follow-up, or who had a confirmed recurrence or de novo metastatic disease at presentation. We sent the BreastQ to 743 patients, and our response rate was 79%. We then excluded those patients who filled out a survey that did not match the surgery they had received, and those who had a confirmed recurrence or a new primary cancer after the BreastQ had been sent. This left us with 560 evaluable patients. Our patient and treatment characteristics are seen here. 90% of the patients were Caucasian. A third had a BMI of 25 or greater. Most were married and reported financially comfortable status. At baseline, 61% reported working full-time, and 86% had college graduate degrees or higher. Most of these patients were early stage, with 14% having stage 3 disease. 72% received chemotherapy, and 66% reported endocrine therapy within 2 years of survey enrollment. Within the cohort, 28% of patients underwent breast-conserving therapy, 20% had unilateral mastectomy, and 52% received bilateral mastectomy. Of those 400 patients who underwent mastectomy, 11% did not have reconstruction, 69% had implant-based reconstruction, 12% had flap or autologous reconstruction, and 8% had unknown or other reconstruction. 99% of the patients having breast-conserving surgery received radiation, and 45% of the patients undergoing mastectomy received radiation. We included the self-reported lymphedema at 1 year as an exposure due to its potential impact on quality of life, and 29% of patients reported this. We then looked at the BreastQ mean scores, and a higher score here indicates a better or higher quality of life. There are 4 domains. Satisfaction with breast assesses a patient's satisfaction with the appearance and feel of the breast. And you can see here that those patients undergoing breast-conserving surgery had significantly higher scores than those undergoing unilateral or bilateral mastectomy. There's another domain that looks at physical well-being, including things like pain and range of motion, and no differences among the groups was seen here. Psychosocial well-being is also assessed in this instrument. those patients who underwent breast-conserving surgery had significantly higher quality of life scores than those patients undergoing unilateral or bilateral mastectomy. And similar findings were seen in sexual well-being as well. We then performed a multivariate analysis looking at factors impacting quality of life in these 4 separate domains. We look at beta, which is the difference in breast Q score here, and a negative beta indicates lower quality of life. A positive beta indicates higher quality of life. And just for point of reference, a large difference is considered something in the 8 to 10 range. When we looked at satisfaction with breasts, patients undergoing both unilateral and bilateral mastectomy had large decreases in satisfaction related to those who underwent breast-conserving surgery. We also saw decreases with radiation and in those patients who reported being financially uncomfortable. In the physical well-being domain, those patients who reported lymphedema had moderate decreases in quality of life versus those who did not, as did those patients who reported being financially uncomfortable. For patients who were greater than 5 years from surgery, they had better quality of life reported as far as physical well-being than those patients who are 1 to 5 years out from surgery. When we looked at psychosocial well-being, undergoing breast-conserving surgery was associated with a large improvement in quality of life compared to those patients having unilateral or bilateral mastectomy. We again saw a decrease in quality of life in those patients receiving radiation, and consistently saw a decrease in quality of life in those patients who reported being financially uncomfortable. In this domain as well, we saw that having a BMI of 25 or greater was associated with a moderate decrease in quality of life. And then in sexual well-being, we did see a large decrease in quality of life for those patients undergoing bilateral mastectomy versus breast-conserving surgery. We again saw that being financially uncomfortable was associated with a moderate decrease here as well. And again, we saw that BMI of 25 or greater associated with a decrease also. In this group, lymphedema was also associated with a small decrease in quality of life. Our study does have limitations. This was a one-time survey of women who were enrolled in an observational cohort study, and we know that preoperative quality of life likely drives surgical choices. Our findings may have limited generalizability to a more diverse population in that the majority of our participants were white and of high socioeconomic status. So in conclusion, local therapy decisions are associated with persistent impacts on quality of life in young breast cancer survivors. Compared to breast-conserving surgery, unilateral or bilateral mastectomy, even with the majority of our patients having reconstruction, is associated with significant decreases in quality of life domains for satisfaction with breasts, psychosocial well-being, and sexual well-being. Thus, knowledge of the potential long-term impact of surgery on quality of life is of critical importance for counseling young women about surgical decisions. So we'd like to thank all those who participated in our study and contributed to our research, as well as all participating sites, study team members, and the organizations listed here for supporting this research. Thank you.